Our next speaker is Maxine Chang Chin. Maxine Chang Chin is the Cancer Risk Assessment Counselor for the Memorial Cancer Institute. She's an advanced nurse practitioner with a specialty in cancer genetics and has been in the field of oncology for over 17 years. Trained at the University of Miami Sylvester Cancer Center, who will discuss what's in your genes.
Good morning, everybody. Thank you for being here. I walked that way because I had a dream last night that I stepped up here and fell, and I wasn't about to make my dream a reality. So today we're going to talk about what's in our genes. Many times patients come in and they have specific questions for me, and I'm kind of going to go over what happens day to day as I meet with patients who have cancer or an entire family that might come in to know what their risk of developing cancer is. I get that question every day. Is the majority of breast cancer hereditary? And the answer is no. If you look at the circle, the majority is sporadic. So lifestyle, environment, we know that impacts the risk to develop breast cancer and other cancers as well. 30% is familial, so we might see something in a family we might not have an explanation for. And they're rare cancer syndromes, 3%. And the rare cancer syndromes you might never have heard of, like Li-Fraumeni syndrome. You might never have heard of Cowden syndrome, but we're going to talk about it a little bit today. And the hereditary breast cancer is about 7 to 10%. Some data might say 5 to 10%, but if you notice, it's not the biggest number. Oops. So that's what I do every day. That's just a simple representation of a family tree or a pedigree. So we're going to look at, is there a pointer on this? We're going to look at the pedigree on the right. It will be your left, my right. Right? Correct? Ah, look at that. Okay, so let's look at this. So we'll talk about this person who we call the proband. That's the person who's sitting in front of me with the questions. So she was diagnosed with ovarian cancer at 46. Circles are women, squares are men. So she has 2 sisters and a brother. That's dad, that's mom. So on her dad's side, her paternal grandfather had prostate cancer at 47. The biggest thing we look at, ages. She's young, so is grandpa. Prostate cancer in a 47-year-old is not what we normally see. Yes, men do have prostate cancer, but it tends to be older age. Look at sporadic. So this is the patient in front of me. She's my proband. She says, my mother had breast cancer at 71, and my paternal grandfather had prostate cancer at 83. And I'm really concerned about my risk to develop breast cancer because my mother had breast cancer. So let's look at the age. Mom had breast cancer, and that's significant for us. However, in terms of thinking about a vast increase in her risk to develop breast cancer, the average age of women developing breast cancer is in their 60s. So a woman at age 71 is important for the patient to know that her mom had breast cancer and be monitored, but we would not offer genetic testing for that. And plus, they're on 2 opposite sides of the family. Fair? Okay. So what do we need to know? What are the risk factors that we can't change? We can't change how old we are. We can't change when our menses comes, whether we have late or early pregnancies. We cannot change the family history that we have. We might not like our families, but we can't change it. It is what it is. And we can't change our race or ethnicity. But this is what we can change. We can change what we do. We can change our alcohol intake. Did you know, and this is me on my soapbox because I say this to the nurses all the time whenever we go out, greater than 5 glasses of alcoholic beverages in a 7-day period increases your risk to develop breast cancer. So when I have this talk with my patients every day, they say to me, but it helps my heart. Okay, so if you want a glass of red wine a day, yes, it will help for cardiovascular health, but it could increase your risk to develop breast cancer. So why can't we balance that? Why can't we drink less, exercise more, eat better, and we get the best of both worlds? So if you come into my office, you know we're going to have this conversation. And smoking, I don't even need to add anything to that because we hear so much about smoking and the risk for cancer. I can move on. And exercise, 30 to 40 minutes of exercise, 4 to 5 days a week will help to decrease your risk to develop cancer, help to decrease your risk to develop breast cancer. So I bought a Fitbit. Does anybody know what that is? I love it. It shames you every day because you think you walk over 10,000 steps, and I thought I did because surely I walk all the time. I looked at it, it was 6,200 steps. So this was 9 at night, and I was hell-bent on getting that 10,000 steps in. So yes, I went for a walk at 9 to 10 at night because I wanted the 10,000 steps in. But exercise also helps to decrease our risk to develop cancer. And these are things that are potentially modifiable. Some of these we really may not even be able to change. What do you need to know about your family history? Everything. You need to know about everybody. You need to be the person in your family that's nosy. You know, in everybody's family, there is that one person who never minds their own business. That person you should get to know. Why? Because there are things about your family that you need to know that you don't know that might impact your risk to develop cancer. Remember Dr. Weingrad talked about the NCCN guidelines? Those are the same guidelines we have to use. The National Comprehensive Cancer Network tells us who in the family, what kind of cancer, what ages at diagnosis do we need to look at. I don't have to read these to you, but look at the ages. You notice prostate cancer before age 55? You notice ovarian cancer at any age. And when we say ovarian, we mean ovarian, fallopian tube, primary peritoneal cancer. Male breast cancer, 1 in 1,000. Pancreatic cancer. Did you know that pancreatic cancer in a family might tell us that there's a genetic abnormality that could increase the risk to develop breast cancer and ovarian cancer? Yes. How about both breast and ovarian cancer in the same person? Or one person with more than 1 to 2 cancers in their lifetime. I met a patient many years ago. By the time she came to us, she had already had a sarcoma. It was a uterine sarcoma. The uterine sarcoma was probably in her early 30s. Then she had stomach cancer. And then when she came to us in her 50s, she had breast cancer. So when we did her testing, she did carry a genetic abnormality that was not BRCA1 or BRCA2. It was the TP53 gene that causes Lee-Fraumeni syndrome. But I'll slip that in a little bit. So what are genes? They're really in nature's blueprints. You get half the genes from mom and half from dad. There was a time we thought that if your father had cancer on his side, don't take note of that because if it's breast cancer, breast goes with breast, so only look at mom's side. Not true. When we think of breast cancer and a lot of the genes that increase the risk to develop breast cancer, you get half from mom, half from dad. So if there's a mistake or a mutation in a gene, that's what we look for that would tell us about a patient's risk to develop breast cancer, ovarian cancer, or other cancers in their lifetime. So when we think of BRCA1 and BRCA2, BRCA just means breast cancer. It's not scientific. So it's breast cancer gene 1 and breast cancer gene 2. Those are the genes we know the most about, and that's where we have all the buzz. When Angelina Jolie had the testing, it really came to the forefront, and there were many people that were saying, well, I wouldn't take my breast off if I had a genetic mutation. So let's see if you wouldn't after today. Oops. So this is information we have about BRCA1 and BRCA2, and both of these genes are called tumor suppressor genes. So think of them as cancer prevention genes. So if they work, they prevent breast cancer, ovarian cancer, and associated cancers. So I like to explain to my patients about the genes this way. Think of a door. A door that opens and closes will keep bad stuff on the outside and the good stuff on the inside. So if that door is missing a hinge, or a hinge is not functioning properly, it's still a door, but not functioning the way a door should function. So these genes are there in our bodies to prevent cancer, but if there's a mutation, instead of preventing cancer, it just stops. So then that is what increases our risk to develop specific cancers. So do we have specific mutations based on ancestry? Yes. Those are specific mutations for people who are of Ashkenazi Jewish ancestry, Eastern European, which would be Lithuania, Poland, Russian, Austrian Jews. There are two specific, so here's what we know for people who are Ashkenazi Jewish. There's a 1 in 40 chance of carrying a genetic abnormality, while the general population is 1 in 400. That's why we ask ancestry, because we need to know who amongst our patients are the highest risk to develop cancer, so we can offer the appropriate testing and be able to do the right thing. So do we know their Colombian mutations? Absolutely. So my Colombian patients, I know there's specific mutations for them as well. And so as we're looking at a family history, we're looking to see what mutations exist in the people of that specific ancestry or ethnic group, so we can also target test. Are there Bahamian mutations? Yes. So when we see our patients that are Bahamian, we know that there's specific BRCA1 mutations. And remember Dr. Weingrad talked about BRCA1? BRCA1 tends to be young women. We see breast and a high risk of ovarian cancer with BRCA1 mutation. And the University of Miami has been making great strides in the Bahamian population. Look at the percentage lifetime risk if somebody carries a mutation. If somebody says to you, well, Ms. Jones, we did your testing and you carry a BRCA1 mutation, so we know that your lifetime risk to develop breast cancer is up to 87%. That's greater than 50% chance. It may not happen though, but there's up to 87% chance that that may occur. That is the decision, those are the numbers that patients hear when they think about having a bilateral mastectomy. And that's removing both breasts even if you don't have cancer. That is to prevent the development of cancer because of those high-risk numbers. Look at the risk for ovarian cancer, 20 to 40%. But once you present up to 87% for breast cancer, somehow that 20 to 40% seems small. But the general population risk is 1.5%. So don't just look at that 20 to 40% as a number. It's compare that to what the general population risk is. And for BRCA2, we include prostate cancer, pancreatic cancer, and melanoma in terms of screening, because we know that gene also, if abnormal, increases the risk of those other cancers. So what about men? Men develop breast cancer too. And if a man carries a genetic abnormality, he too can pass it on to his offspring. If there's a mutation on BRCA1 or BRCA2, it's a 50-50 chance to pass it on to the offspring. And they may never develop cancer, but we know their risk is high based on the numbers we just looked at. This is my love. This is what I do. So I want to walk you through a family tree that I made up out of my head. So remember, this is our proband. These are her siblings. This is her father. That's her mother. And this is the paternal family history. Because remember I said, don't discount stuff on your dad's side because it matters. So my proband came in because she was diagnosed with bilateral breast cancer. The first time she was diagnosed with breast cancer was at age 34. The second time was at age 36. Her siblings, both male and female, have not developed any cancer. Her father has no cancer. Her mother has no cancer. So then she says to me, how could I ever have breast cancer? My parents don't have cancer. There are other people in my family with cancer, but they're not like my family, but they are. So if you look, dad's sister, the patient's paternal aunt, 72, no cancer. Dad's 71, no cancer. But look, dad's other sister had breast cancer at 42 and ovarian cancer at 45, and she died. Dad's parents. So this patient's paternal grandmother had breast cancer at 52 and she was still alive. She was really old. Her paternal great aunt, that grandmother's sister, breast cancer at 45, she died. And another sister of her grandmother had no cancer, but she had her uterus and ovaries removed at age 46. So when she was still premenopausal, she removed her ovaries, which helped to decrease her risk to develop breast cancer. However, her daughter had breast cancer at age 50. So when we tested our patient, she carried a BRCA1 mutation. And so for BRCA1, we look at young ages, we look for ovarian cancer in the family, we look at some colon cancer data shows, but we really need to know, first of all, the family history so we could draw a family tree and be able to see what's called hereditary susceptibility, go as far as we can in the generations, and we can see a pattern from one generation to another. Even though the parents have had no cancer, this patient carries a mutation. So what do we look for when we see BRCA2? Well, this was a male patient. So now we have a male patient diagnosed with breast cancer at 52. He has two sisters. They don't have cancer. Dad had prostate cancer at 64 and melanoma at 72. And grandma, breast cancer at 36. There's ovarian cancer at 68. But look at that pancreatic cancer in a great aunt. That great aunt was a nun. So when we see pancreatic cancer, we do ask about alcohol use. This great aunt was a nun, didn't use alcohol, didn't smoke, so she had no lifestyle changes that would explain that pancreatic cancer. Male breast cancer, we really look at the BRCA2 gene, and he carried a BRCA2 mutation. So when we're offering testing, just because he's male and there's pancreatic cancer in the family, we don't just offer BRCA2 alone. We offer the entire BRCA1 and BRCA2 panel. And let me kind of tell you what's new for 2014. For 2014, we're looking at cancer panels. So when I say a cancer panel, I mean a few genes that we know could increase the risk of breast cancer or cancers in general. So the panels that we're looking at may range from 7 genes, which may be those 6 to 7 genes that may be the genes that are highest risk to develop breast cancer, such as BRCA1, BRCA2, CDH1, STK11, TP53, P10, PALB2. Those genes we know are high risk to develop breast cancer. So if somebody had BRCA testing with a significant family history and did not find a genetic abnormality, there are other genes to look at. So what you do is you go back to your doctor and say, does my family history meet the criteria to look at other genes that could cause this breast cancer? Let's touch on ovarian cancer for a minute. Yes, we do know this. Breast cancer is genetically linked to ovarian cancer. But that does not mean that if somebody has breast cancer, they will automatically develop ovarian cancer. And it doesn't necessarily mean that they're higher risk. It means let's do the genetic testing to see if we can figure out if there's a genetic abnormality that could increase the risk of developing an ovarian cancer, because if we have that information, we'll offer surgery to decrease the risk by removing the ovaries and fallopian tubes. A pap smear does not detect ovarian cancer. And the symptoms of ovarian cancer are vague. I had a patient, all she had was shoulder pain. Sometimes shoulder pain is just shoulder pain. But it was shoulder pain followed by what we call increased abdominal girth. where her abdomen just swelled up for no apparent reason. So I want you to look at this with me to see why it is that I would say to you, Pap smear does not detect ovarian cancer. That's the cervix. That's where we do the Pap smear. That's the ovary. Two different positions. So when you go to your gynecologist and the gynecologist does a pelvic exam that we hate scooting down on that table, there is value to that. That's the way we get that pelvic exam to see if there's anything abnormal in our pelvic cavity. I'm not saying that we should run to get one every day, but you need to know how often you should see your gynecologist. And when they do that pelvic exam, it's because they're trying to see if there's something abnormal that needs to be acted upon now. Remember, we talked about the lifetime risk of ovarian cancer. The general population is 1.5%. And if somebody carries a genetic mutation, the numbers are higher than that 1.5%. And that's why we want to know which of our patients carry a genetic abnormality in BRCA1 or BRCA2 that might give us those high risks so we can discuss options with them. And yes, sometimes we have very young women who are 28, they're 35, and they carry a genetic abnormality and they say, I don't really want to remove my ovaries. And we're not saying that we have to, but we need to send them to the reproductive endocrinologist that can talk to them about what do we need to know for the next generation. Can we test the embryos to see if they carry genetic abnormality and select those that do not? There's so many options for young women these days that you might not even be aware of, but reproductive endocrinologists can help. Oh, and so you see the symptoms. Remember I said it's very vague. So get that pelvic exam when you should. Know your family history if there's ovarian cancer, and let your healthcare provider know. We can only do with what we know. So if you never let your healthcare provider know that you have an aunt or a cousin or anybody with ovarian cancer, you're cutting off their hands. If we don't know, we can't document. If we can't document, we can't offer you the testing that you may need. So these are the risk factors for developing ovarian cancer: a family history of ovarian cancer, a previous cancer diagnosis, increasing age. The risk of ovarian cancer increases as we age, and that does not mean that we're going to have ovarian cancer in a lifetime, but you need to know that the risk increases with age, and never having been pregnant is also a risk. So what else do we need to know? If you meet the criteria to do testing, and by meeting the criteria, I mean we look at the family history based on those NCCN guidelines. We have the family history put up in a pedigree. We've identified the most appropriate person to test. So let's do that. The most appropriate person to have the testing is the person diagnosed with cancer. Because what we're trying to do is determine why they develop cancer, breast or ovarian. So we will offer the testing to that person and obtain the most informative information. So if I have a young woman who comes to me and she says, I want to have testing because my mom and her sister and my cousins all had breast cancer. My cousin had bilateral breast cancer at 40, and I'm 41 and I'm scared. My first thing to her is, has anybody in your family had the testing? And if she says no, I will say, here's what we do. Let's do the risk assessment, calculate what your risk is to develop breast cancer, start screening you appropriately while the other family members who are most appropriate to test have the testing that's needed. So what if she comes back and she says, I talked to everybody, nobody's interested? Then and only then would I now think of her to have the testing, understanding if I have a negative test result, it's not really that informative because I'm not comparing her to anybody who has cancer and had the testing. But it's better than nothing. But we could test her, and if she carries a genetic abnormality, now we know the percentages, and now we can talk about surgical options and even taking a pill for prevention, because we do have medications like tamoxifen that we give for the prevention of breast cancer. So we draw blood, we can use saliva or a buccal wash, and we send that off. The testing is expensive, but the cost has decreased over time. Initially, when only one lab was doing the testing, it was about $4,000 for the BRCA1 and BRCA2 panel. Now we have many labs that do testing, but the biggest thing is making sure that the lab you use for the testing is CLIA approved. Anyone can say I can offer testing, but you want to make sure that that testing is reproducible and reliable, because it's your money. So as we do the testing, we can look at the family history and see, are we looking at 2 genes or are we looking at a panel of genes, and what are we going to do with the information? I am a huge proponent of having the counseling before the testing. Why? You need to know what your options are. You need to be prepared that we might not expect it to be positive, and it is. And what are you going to do with those results? The results take maybe 2-3 weeks, sometimes 4 weeks, depending on insurance, because we have to get insurance approval for many of the testing that we do. And now, a lot more insurances are covering testing. Medicare does not cover genetic testing routinely for people who are unaffected. That is how it is, but then there are now other labs that, since the cost of testing is less, people have the option to pay out of pocket, and it's not an arm, a leg, and a left eye. So let's go over this one more time. What do you need to know? You need to know your family history. Who do you need to know it about? Mother, father, sister, brother, niece, nephew, aunts, uncles, cousins, great aunts, great uncles, their children, to just give us an idea of what's happening in your family. When you gather that information, talk to your doctor about that. Whether it's your gynecologist, it's your primary doctor, your oncologist, tell someone so they can document it and refer you appropriately. Remember, there's more out there than just BRCA1 and BRCA2. Remember, knowing the cancers in your family will help us to know which of these genes are more likely than not to be the cause of the cancers we see. Consider having the genetic testing if there's that strong family history. If we can find the most appropriate person to test, let's test that person first. If there's no one available, either because they decline testing or they're deceased, then make the decision if you're ready, both emotionally and psychologically. Implement the lifestyle changes we talked about, the things that we have control over. Keep your follow-ups on time. Remember, all this knowledge is powerful. And 2 things I want you to take away today. With ovarian cancer, it whispers, know your family history so we can listen. And with breast cancer, we're always trying to find that cure. Thank you. Does anybody have any questions? I know. Yeah. So if someone has had genetic testing and it's negative, we look at that family history again, and then we see if the patient meets the criteria for a panel. And the panel will look at the other genes that are high risk to develop breast cancer. And again, it has to match the NCCN guidelines of the cancers in the family, and we offer the testing for those other genes that could be high risk. Sometimes patients will say, I want everything. Give me the 29 genes. I want to know everything there is to know. But a lot of the genes, we know that they're moderate risk or low risk for breast cancer, and there are other cancers as well. And we don't have the NCCN guidelines right now to back us up on everything. But the ones that are high risk, we do have NCCN guidelines. So yes, it's something for us to talk about again. There's a lady in the back, and then I do you. You know, I think I'm old and deaf, so. Oh, the buccal wash. So we can, some of the labs will give us like a mouthwash, and you swish it around in your mouth and you spit it in a tube. And some we can do by saliva. You just spit in a tube, and believe it or not, it works. So we give you the mouthwash, you swish it around, spit in a tube, we send it away, and they can give us results to see if you carry a genetic abnormality or not. Initially, I thought that's not gonna work. So I had the lab to convince me, because if I'm doing this test for the patient, I wanna make sure that the results I'm giving them to make decisions about are correct. So I had them do a pilot test on a few patients of mine that did the buccal wash, have the blood drawn, send it in, but I didn't put exact first name and last name. I did John Doe, Jane Doe, just so that I'm sure. But I did like the same date of birth. And they sent it back and it was the same results. So yes, I've seen that it's reliable. Okay, the ballpark figure to pay for the test out of pocket. So there's one lab that says $1,500. There's some labs that will do $3,000. It depends on what you're doing. But you want to make sure that when you're having the testing done, it's a reliable lab. I didn't choose. Okay, so I answered your question already. All right. Okay, so let me see if I got this right. You're a 5-year breast cancer survivor, significant family history, and you want to know, should I be talking to my doctor about getting additional testing? Yes, because so much has changed in the world of genetics. I remember when I started this 10 years ago, we talked about BRCA1 and BRCA2. We talked about the other genes as well if there was a family history, but now it's almost like the door is opened up to so much more. And one of the big things I say to my patient is, my patients are, have a change in the family history, tell me. If there's a change in your personal history, let me know, because then I update that family history, and maybe it looked like one thing before, and a few other cancers just makes me see it a whole different way. So for us to get the answers and do the right thing for you, we have to look at what the most current data is that we have. And we have the NCCN guidelines to help us. So if I know I'm testing somebody and I'm just not comfortable with all that's there, I refer them. I refer them to somebody who might see these cancers more so than myself, so that I'm getting the answer for the patient. It doesn't matter to me where I get it from, but as long as I get that information so I can do what's best. And somebody. I heard cigarette smoking and breast cancer. The exact link we don't know, but we know that smoking does increase the risk of cancer, inclusive of breast cancer. Somebody asked me yesterday because they read an article that said that if a man smokes or a woman smokes, being in the same house all the time, somehow the breast absorbs that. I don't know if that's true or not, but all I can tell you is that cigarette smoking is the #1 killer of both men and women for lung cancer. It increases the risk of so many cancers, inclusive of breast cancer. The exact dynamics, I don't know, but I know that it happens. And we see it in our data all the time. I was even reading something the other day about cervical cancer and thinking about the risk of developing cervical cancer because somebody smokes. If a woman smokes and she's doing surgery, healing is compromised. We hear that all the time. And also if a woman smokes and we want to give tamoxifen for prevention, we stop because smoking increases the risk of blood clots. So we don't want to give a medication that has that as a possible side effect if the patient already has a lifestyle that increases the risk of that. Does that help? Oh, but we're seeing smoking and many cancers to get linked together. We haven't seen, like when you do a genetic test, we don't have many genes that we look at and say, oh, if somebody has lung cancer in their family, definitely it's this gene. But we see smoking increase in the risk of many cancers, inclusive of breast cancer. Sometimes we don't know. Sometimes we don't know.
If you've had a family history, like, I've never even thought of it that way because my two uncles died of prostate cancer. I had a brother that died of throat cancer. And it got kind of scary because my father died at the age of 27 and my brother died at the age of 46. So when he turned that age, we got my family.
But-
I was diagnosed at the age of 52 with breast cancer.
But that's why now when we see patients with a family history of lung cancer, we're talking about the CT screening. And they're doing the CAT scan initiative where you look at the number of packs per year, number of packs of cigarettes per year that the patient smokes in addition to their family history. And then they recommend doing a CAT scan or putting the patients on studies because we are looking for those answers too. Is it my stop sign? Okay. Oh, she has one question. The ultrasound there is no great way to find ovarian cancer at an early age, honestly. And so that's why telling your family history to your GYN doctor so that they can monitor you in the right way based on the family history. That pelvic exam, you can't beat that pelvic exam to feel a mass above and beyond an ultrasound. So if a patient comes in with symptoms, I'd still suggest the pelvic exam as the go-to. And then the gynecologist is going to discuss what is the value of the ultrasound. I tell patients don't focus on just getting a test or a blood test like the CA125 and focus on a number. We have to look at the patient and look at the symptoms and do a physical exam. And so I'm a big proponent of discussing all of that with the gynecologist. What is the best thing for me? This is my family history. Do you think I would benefit from doing this? Okay, thank you.